Now I'd like to invite Dr. S.K. Chaudhary sir, the last talk of the course for retinal examination for postgraduates.
Good morning and welcome to all of you. Although this session was planned for PG students, but I'm not able to see any. But still, uh, so I'll be sharing my experience regarding retinal examinations here. So the natural advantage about retina is this: that retina is fully visible. It's not hidden like optic nerve, choroid, or ciliary body, and all disorders of retina are also visible, and we have multiple diagnostic tools, and we need not to guess anything in retina. Everything you can see, you can diagnose. And you must know the normal appearance of the retina so that you can make the difference that there is something abnormal in the retina, and then you can think of making the diagnosis. So you must know what are the common retinal disorders so that you can plan your investigations, and you can plan your things to reach the conclusion and diagnosis. So commonly we know that diabetic retinopathy is there, in which the changes are mostly located at the posterior pole. Same is the hypertensive retinopathy, changes are at the posterior pole. Age-related macular degeneration, CNVMs, disease of posterior pole. Retinal vein occlusion, posterior pole. Retinal detachment, it involves initially the periphery, then comes to center. Lattice and breaks, these are the problems of periphery. Retinal degenerations involves whole of the retina. Same dystrophies involve whole of the retina. Vasculitis, usually peripheral vessels. CSCR, central retina, posterior pole. And retinitis, viral retinitis involve most of the retina, and tumors depending upon type of tumor may be at posterior pole or at periphery. So what all equipments we have to examine the retina, and we must know the ideal use of them. So we can see retina even on the torchlight also, like if retina is fully detached, and certain tumors like uh, this retinoblastomas sometimes visible on the torch. Then slit lamp, we can see many things in the retina even on the slit lamp also, particularly in high myopathic patients. And then direct ophthalmoscope is a very handy and commonly useful tool for residents, particularly in initial days. Then indirect ophthalmoscope, then slit lamp biomicroscopy, USG scan, FFA. This is also the list of commonly available equipments we have: OCT, OCTA, ICG, FAF, ERG. So we have all these tools to examine the retina and to reach the diagnosis, but we have to plan the ideal use of these equipments for particular situations to get best use of these things. So direct ophthalmoscope, the advantage is the magnification here is 15x. It has got quite short learning curve. It is portable, can be taken to wards for bedside fundus examination. But the disadvantage is it has got only monocular view. We have to see the things with only one eye. So stereopsis is missing in this examination. But the diagnostic utilities of direct ophthalmoscope are a diabetic retinopathy, hypertensive retinopathy, and age-related macular degeneration, because these things are usually visible at the posterior pole of the retina. Then indirect ophthalmoscopy, the advantage is it has binocular view, so stereopsis is present, and but the magnification is lower than direct ophthalmoscope, only 5x. It has got slightly long learning curve in comparison to direct ophthalmoscope, and it is not easily portable, because if it's it is to be attached with the electric connection. Even if it is battery operated, even then also it is a big box, not easy to carry it to the wards. Diagnostic utilities are peripheral vasculitis, lattice, breaks, ROP, etc. And while examining retina with indirect ophthalmoscopy, you must know these coding colors for charting your findings. Then slit lamp biomicroscopy, it is a really good way of examination, but long learning curve, because first you have to learn the slit lamp examination, then use of 90D. So in this examination we can use either a 90D or 78D. The advantage of 90D it has got wider view, but magnification is slightly lower. 78D has got narrow view but slightly more magnification. The big advantage of slit lamp biomicroscopy, it gives you binocular view, and magnification is adjustable magnification. You can see the things in magnified view also with the use of your slit lamp magnification. And stereopsis of course present in this equipment, and there but the learning curve is slightly long, as I told you, because first you have to learn the use of slit lamp, then 90D. And of course this is not portable. Patient has to come at the slit lamp. And diagnostic utilities are like CSME and CSR. In both of these, the disease is present at the posterior pole, and you need to have good binocular view to diagnose them. And particularly in clinically significant macular edema, this method of examination is required to label the things. Then B-scan is very important tool in retina examination, and the frequency used is 10 kilohertz. And in particular situations when the media is hazy because of cornea or because of cataract, then you have to use this equipment to diagnose the things behind. And sometimes you need to use it in uncooperative patient also, when patient is not able to tolerate the light and not able to cooperate your instructions. And sometimes you need to use it to confirm your ophthalmoscopic findings also, like in shallow retinal detachment or PVD, and also used to locate the intravitreal foreign body. And and particularly posterior scleritis, this T sign is very important in B scan to confirm the posterior scleritis. And certain things like choroidal detachments are difficult to diagnose on fundus examination, and sometimes you need the help of B scan in such situations. FFA these days, this is going to slightly towards back seat because it's an invasive procedure, but still it's very important tool to detect and confirm the retinal neovascularization, to detect and or to rule out the macular ischemia, to detect or rule out the CNP areas in the periphery, to confirm leaky, whether the microaneurysm is leaky or non-leaky, so that you can plan your treatment accordingly, to detect and locate the leak point in CSR, so that you can plan for laser, and high diagnostic value in macular telangiectasia. So as you can see in this picture, you can easily see a neovascularization, capillary dropout areas, and laser spots also, plus microaneurysms. Very good tool to see all these things. Then wide field FFA camera, it has a range up to 200 degrees in comparison to conventional FA cameras who have range about 50 to 60 degrees. And this is very important to detect neovascularization at peripheral retina, to see severity of ischemia in retinal periphery, and very useful in Coats disease and ROP. OCT, this is getting popular these days because this is non-invasive process, and this is used particularly to examine the vitreoretinal interface, to quantify the macular edema in DME and RVO, to detect and measure fluid in wet AMD, to monitor the progress of CSCR, to detect polyp in wet AMD. And you must know the normal OCT appearance, normal layers appearance, to make your diagnosis in OCT. And this is there, the learning curve is quite short in cases of OCT. So these are certain slides showing CSR, AMD, and diabetic retinopathy. Then Okta, this is a very useful tool these days, particular in some certain particular situations, and this is also non-invasive. It has a dual advantage of OCT and FFA. You can see the circulation without injecting the dye. It has got diagnostic value to detect CNVM at very early stage, to detect capillary dropouts at macula without injecting dye, and to detect RAP lesion, RAP lesion in wet AMD. And these are few pictures of Okta. You can see very well the new vascularization in non-neovascular layers of the retina. ICG useful in a few peculiar situations, like to detect occult CNVM, to confirm polyp, and to demarcate tumors. But again, this is invasive procedure and not commonly available at many centers. Then this is non-invasive procedure, but this is of very useful value in certain conditions like retinal dystrophies and retinal degenerations, CSR, and choroiditis. And this instrument make use of your lipofuscin pigment, and can make out many useful diagnoses which cannot be diagnosed with other equipments. ERG not very commonly used, but very useful to detect the function of the retinal cells, and sometimes anatomy is normal but functions are deteriorated. You can use these equipments, and particularly this is useful in rod and cone dystrophies and retinitis pigmentosa. And as you can see in the picture, the in abnormal cases, in disease cases, the ERG is flat. Similarly, EOZ, this is very useful tool for photoreceptor disorders and breast vitelliform dystrophies, and changes you can detect easily in the reports. AMSAL grid, this is used to monitor the disease, particularly CNVM, CSCR, and macular holes. And perimetry occasionally we do in retinal cases, particularly in BRAO and BRVO, not of very useful value.